Okay, let's dive into a topic that will really get you pumped up: heart failure. This chapter is all about what happens when the heart stops working like it should. Like an old car that just can't go any further, the heart can fail gradually or in a fiery, spectacular fashion. This chapter will cover the usual suspects: chronic heart failure and acute decompensated heart failure. We'll also dive deeper into some of the causes of heart failure: cardiomyopathies, myocarditis, and pericardial disease. Are you ready to dive in? Good, because we're going under the sea for this sketch, the first of our three-part series on heart failure. This sketch is focused on the clinical presentation of chronic heart failure, which you'll primarily see in the outpatient clinic. In part two of this series, we'll cover the management of chronic heart failure. Finally, we'll finish up in part three with a discussion of acute decompensated heart failure, a super common reason for admission to the inpatient medicine wards. Let's get started with some important definitions of what this mythical condition called heart failure actually is. Heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. The result is a classic set of symptoms and signs that we'll dive into in a moment. Our recurring sketchy symbol for heart failure is this floppy heart balloon being held by our mermaid protagonist. Get used to it, because we'll be bringing back this symbol over and over. Heart failure can be classified into two different groups based on whether the underlying dysfunction is a squeezing problem or a filling problem. Systolic dysfunction is a fancy term that simply means the left ventricle can't squeeze out as much blood with each contraction as it should. When heart failure occurs primarily due to left ventricular systolic dysfunction, we call that heart failure with reduced ejection fraction. To symbolize heart failure with reduced ejection fraction, we've drawn in this awesome sea creature happily playing away on its droopy heart shaped accordion. I don't know how much music you're going to make with all those holes in it, but hey, we're under the sea. More power to ya. Yikes, watch where you're playing that thing. Don't you know these sewers drain into the ocean? Oh, wait. Yeah, you probably do. Anywho, take a look at that falling slice of cake before it goes away for good. Notice how it kinda looks like a less than 40? Let that help you remember that officially, reduced EF is defined as an ejection fraction of 40% or less. For reference, a normal EF is between 50 and 65%. Diastolic dysfunction, on the other hand, is characterized by an inability to adequately fill the left ventricle. Since the left ventricle is still able to squeeze normally, ejection fraction is preserved, which is why we call it heart failure with preserved ejection fraction. At Sketchy, diamonds aren't forever, they're for diastolic. Hence the diastolic diamonds on this overwhelmed dolphin server having difficulty filling those glasses. It's alright, champagne pours differently under the sea. You'll get it. The definition of preserved EF is less unanimous than it is for reduced EF. But for the most part, people will agree that an ejection fraction greater than 50% can be called preserved EF. Hence the candles on this cake, looking awfully like the number 50. Wow, 50-year-old fish? Good for you, buddy. Keep in mind that, in reality, most patients with heart failure have elements of both systolic and diastolic dysfunction. Whether the problem is a weak pump or inadequate filling, serious problems arise when the heart starts to fall behind in dealing with all the blood returning to it. The pathophysiologic result of heart failure is an increase in the pressure in the left ventricle, known as LV and diastolic pressure, represented by this puffed up heart shaped pufferfish. Since the heart is an open circuit, this pressure gets transmitted backwards into the pulmonary circulation, followed by the right ventricle, and ultimately the systemic venous circulation. As pressure builds up in these different places, so do the classic signs and symptoms of heart failure, which we'll get to right now. When LVEDP transmits backwards into the pulmonary circulation, that extra pressure leads to fluid being pushed out of the pulmonary vasculature and into the alveoli. As a result, heart failure affecting the left ventricle tends to produce respiratory symptoms. The most common presenting symptom of heart failure is dyspnea on exertion. It's represented by the sea turtle struggling to blow out a puff of air as he tries to swim. He is not having a good day. If heart failure makes you feel like just lying around all day, you're not alone. Unfortunately, heart failure patients aren't going to be among them. That's because many patients with heart failure present with orthopnea, or shortness of breath that occurs while lying supine and is relieved by elevation of the head. Hence this supine sea turtle, looking like she's in trouble. Classically, patients with orthopnea report sleeping on multiple pillows at night. This is why you've probably been told to ask your patient how many pillows they sleep on. Orthopnea is highly suggestive of heart failure. If you think heart failure goes away at night, dream on. Just like this sleepy anglerfish being awakened by those rowdy reptiles, patients with heart failure may complain of paroxysmal nocturnal dyspnea, which refers to awakening from sleep with shortness of breath. The presence of PND is another specific symptom and more than doubles the likelihood of heart failure in your patient. Pulmonary vascular congestion doesn't have to cause dyspnea. Many patients with heart failure will complain of a non productive cough that's often worse at night when the patient is supine. Hence the sea turtle coughing up a storm. Shh, keep it down. You're going to make angry angler even more, well, angry. Lest you think the respiratory symptoms stop there, we've got one more for you. Patients with heart failure can present with wheezing. That's right, wheezing. Represented by our recurring sketchy symbol, the loud party blower. It's not just for obstructive lung diseases. In fact, wheezing related to heart failure is often referred to as cardiac asthma. Sneaky test writers may try to trick you into thinking a patient has asthma when they're actually presenting with an uncommon symptom of heart failure. Therefore, when an older patient presents with wheezing, think heart failure, not asthma, especially if they're presenting with wheezing for the first time. Asthma is much less likely to show up out of nowhere in an elderly patient compared to heart failure. Respiratory symptoms reflect fluid overload in the pulmonary venous circulation. When the elevated LVEDP in heart failure starts transmitting back to the systemic venous circulation, you'll start seeing symptoms related to systemic fluid overload. One of the most common symptoms of systemic fluid overload in heart failure can be seen in the legs of this octopus percussionist. I wish I could play the drums with 8 limbs. Or at all. Anywho, as the increased intracardiac pressures back up into the systemic venous circulation, fluid gets pushed from the veins into the interstitial space, leading to peripheral edema. Edema most commonly occurs in the lower extremities due to the added pressure from our good friend gravity. It's important to note that as an isolated finding, peripheral edema is very nonspecific. In older adults especially, venous insufficiency is more likely than heart failure to cause lower extremity edema. That's why the diagnosis of heart failure is based on a constellation of findings. Similarly, retrograde transmission of increased pressure in the systemic venous circulation can make its way to the liver, resulting in hepatomegaly and ascites. 2 exam findings we'll discuss later. If this is the case, your patient will most likely complain of abdominal fullness or distension, much like the body of this big bloated octopus. Earlier, we mentioned that one of the most common presenting symptoms of heart failure was dyspnea on exertion, and that's absolutely true. Over time, however, as heart failure becomes more severe, those symptoms will progress from occurring during exertion to being present even at rest. How heart failure affects a patient's activity level is actually pretty important. Important enough to warrant its own scale. The degree to which heart failure symptoms limit a patient's activity is quantified using the New York Heart Association, or NIHA classification scale. Like the letters on that sunken fishing boat. Class 1 is defined as having no symptoms with ordinary physical activity. Just like this fish, busting through that net with impunity. In Class 2, patients start having heart failure symptoms with ordinary activity. Kind of like this fish, having a bit of a tough time escaping the net. At Class 3, patients have symptoms with less than ordinary activity, like this guy, breathing hard as he tries to swim out of the net. Finally, in NIHA Class 4, patients have symptoms at rest, like this fish that's just giving up and accepting its fate. Keep the NIHA classification system in mind, as your attending will often ask you about it in your assessment of the patient. One of the most interesting and frustrating features of heart failure is that there are so many different etiologies. When you suspect heart failure in your patient, be ready to ask about a bunch of potential causes. Fortunately, we at Sketchy are ready to give you a hand. Let's start with the conditions classically associated with systolic dysfunction. Once again, remember that virtually every condition associated with systolic dysfunction can also cause diastolic dysfunction, and vice versa. These categories are really to help you separate out the most common causes of each type of heart failure. By far the most common cause of heart failure with reduced EF is ischemic heart disease, represented by the black heart pendant on this merman band leader. This includes acute MI, represented by our recurring sketchy symbol, the broken heartstring on that heart-shaped guitar, and long-standing coronary artery disease, represented by his red coronary crown filled with that puffy yellow cap. Anywho, regardless of the specific cause, ischemic heart disease impairs the ventricle's ability to squeeze that blood out. Hence, heart failure with reduced ejection fraction. After ischemic heart disease, dilated cardiomyopathy is the next leading cause of heart failure with reduced EF. At Sketchy, dilated cardiomyopathy is represented by a big red dilated heart bag, just like the body of this red dilated jellyfish, being used as a cello? Wow, they're creative or sick down here under the sea. I don't know which it is. For all the details about dilated and other types of cardiomyopathy, Check out our cardiomyopathy sketch later on in this chapter. Be sure to ask about a history of heart murmurs, as valvular heart disease, represented by the valve breaking off the saxophone, can cause systolic dysfunction and lead to heart failure with reduced EF. Remember, just because the conditions we mentioned earlier are classically associated with systolic dysfunction and reduced ejection fraction doesn't mean they can't cause heart failure with preserved EF. It's just not as common. With that in mind, let's move on to conditions that are classically associated with diastolic dysfunction and heart failure with preserved EF. By far, the number one cause of heart failure with preserved EF is chronic uncontrolled hypertension. Hence our recurring sketchy symbol for hypertension, the steam coming out of that blowfish's ears. Chill, buddy, before you give yourself a stroke. The recorder's not that hard to play. Over time, uncontrolled hypertension results in concentric hypertrophy of the left ventricle, reducing its compliance, expansion, and ability to fill with blood. Another important cause of diastolic dysfunction is restrictive cardiomyopathy. Restrictive cardiomyopathy does exactly what its name suggests: restrict the diastolic expansion of the left ventricle. Just like how this harp is restricting the movement of that heart shaped fish. Common causes of restrictive cardiomyopathy include amyloidosis, hemochromatosis, and sarcoidosis. For more details on restrictive cardiomyopathy, head over to our cardiomyopathy sketch. Don't forget about the family history. Hypertrophic obstructive cardiomyopathy is an important cause of heart failure with preserved EF. At Sketchy, hokum is represented by this fish struggling to blow into this heart-shaped set of bagpipes. Why? Because we're under the sea, that's why. Oh, wait, you mean, why is he struggling? Because the bagpipes are obstructed. That's my bad. Anywho, hokum is inherited in an autosomal dominant fashion, so make sure to ask about a family history of sudden death at an early age, especially while exercising or playing sports. Now, heart failure isn't always caused by low cardiac output. There's one uncommon type of heart failure with a unique physiology that you should be familiar with: high output heart failure. You might think that high cardiac output and heart failure don't belong in the same sentence, but here we are. High output heart failure is typically caused by conditions resulting in hyperdynamic circulation, such as severe chronic anemia or hyperthyroidism, or decreased systemic vascular resistance, such as AV fistula, thiamine deficiency, or pregnancy. Really, undersea creature band? You made the shrimp play the drums? That's literally the reason octopi exist. No wonder Shrimpy's exhausting himself trying to keep up. Either way, just like this band's overworked drummer, over time, and especially in conjunction with other underlying heart disease, an unsustainably high cardiac output will eventually wear down the heart, resulting in, yep, high output heart failure. These conditions comprise the most common causes of heart failure. Now, let's round out your history with a few more questions to ask your patient. Make sure to ask about a history of cardiotoxic medications. The main drugs to know include the chemotherapy agents doxorubicin, represented by our recurring sketchy symbol, the box of rubies, and trastuzumab, represented by that intricate tapestry lying beside the box. These two medications are so commonly associated with heart failure that patients who are started on them often receive echoes to establish their baseline cardiac function before starting chemotherapy. Have you ever gone out to the bar and had one too many drinks? A few too many? Maybe enough to dilate your heart? While you probably shouldn't phrase your social history question to your patient quite that way, chronic alcoholism is one of the most important causes of dilated cardiomyopathy and heart failure with reduced EF. That's why we've drawn in these fizzy champagne bottles, ostensibly to celebrate whichever fine bachelor our mermaid protagonist chooses to be with. Alcoholic cardiomyopathy typically only occurs in chronic heavy drinkers. We're talking multiple drinks a day over years to decades. Even though heart failure is a clinical diagnosis, the history alone is insufficient to diagnose a patient. Let's take a look at some of the most important objective findings to watch out for in a patient you suspect has heart failure. Most patients you'll encounter in the clinic with chronic heart failure won't have any vital sign abnormalities of note. But patients with advanced heart failure may have such low cardiac output that you might see resting sinus tachycardia, represented by our recurring sketchy symbol, the heart watch. Think of tachycardia as the failing's heart way of compensating for a progressively declining stroke volume. When heart failure becomes so severe that even jacking up the heart rate isn't enough to maintain adequate cardiac output, you might see a unique and concerning exam finding: cool, pale extremities. Just like this pale-looking doll with blue arms and legs, patients with severe heart failure and decreased cardiac output won't be able to pump out enough blood to every part of the body, so the body clamps down on blood flow to the extremities through peripheral vasoconstriction to divert blood to the vital internal organs. While it's not entirely predictive, decreased cardiac output should be suspected when a heart failure patient's pulse pressure drops below 25 millimeters of mercury. When you're examining a patient with heart failure, there are a bunch of findings to look out for. To help you remember them all, let's segment them into cardiac findings and exam findings of fluid overload. And since this is heart failure, the cardiac exam is going to be front and center. Of all the physical exam findings you can think of, an S3 gallop is the most specific for the diagnosis of heart failure. The S3 gallop is classically described as an extra heart sound heard over the apex just after S2 in early diastole, sounding like blood sloshing in to a volume overloaded left ventricle. To remind you of both the rhythm of the gallop as well as the pathophysiology behind it, we've made our recurring sketchy symbol for S3 this S3 slushy cup. Try not to think about the sadness of finding slushy cups at the bottom of the ocean. Don't just listen to the heart, however. Palpate the patient's chest for the point of maximal impulse. A laterally displaced PMI, just like the heart pendant floating laterally away from the statue of Prince Charming, is indicative of left ventricular enlargement and is often seen in patients with heart failure. To count as laterally displaced, the PMI should be palpated lateral to the midclavicular line. In addition to these cardiac findings, some of the most well-known exam findings of heart failure are those of volume overload. That's where the congestive and the old school term congestive heart failure comes from. The three major manifestations of volume overload in patients with heart failure are pulmonary congestion, elevated jugular venous pressure, and peripheral edema. Pulmonary congestion most commonly manifests as inspiratory crackles, also known as rales, heard at the lung bases bilaterally. At Sketchy, lung crackles are represented by our recurring symbol, the crackly Velcro at the bases of Prince Charming's vest. Even though crackles are an oft-mentioned exam finding in heart failure, they're more commonly found in acute decompensated heart failure rather than chronic compensated heart failure. When increased cardiac pressures transmit over to the systemic circulation, one unique exam finding you'll see is elevated jugular venous pressure, or JVP. At Sketchy, JVP is represented by our recurring symbol, the big blue dilated JVP jugs. With the patient sitting at a 45-degree incline, the JVP can be estimated by measuring the height of the pulsations of the right internal jugular vein, hence the R-shaped handles on those big blue jugs. A JVP higher than 4 centimeters above the sternal angle is considered abnormal and is one of the most accurate markers of volume overload in patients with heart failure. Systemic venous congestion in heart failure can also manifest as peripheral edema, most commonly in the lower extremities like the feet and ankles. Hence our recurring sketchy symbol, the wide floppy pant legs floating out of the dresser. Since leg swelling can be caused by a number of conditions, such as venous insufficiency in older adults, make sure your patient has other signs of volume overload, like elevated JVP, before attributing it to heart failure. In addition to the peripheral circulation, volume overload can also occur in the splanchnic circulation. On physical exam, this can manifest as hepatomegaly, represented by the liver-shaped spot on this manatee, and ascites, represented by the bulgy yellow inner tube around its waist. Since a number of other conditions, like liver disease, can also cause splanchnic congestion, there's a test we can use to differentiate between cardiac and non-cardiac causes, the hepatojugular reflux maneuver. Hepatojugular reflux, also known as abdominojugular reflux, is elicited by applying firm pressure to the right upper quadrant for 15 seconds. If you see a sustained elevation in JVP, boom, your patient's hepatomegaly is actually caused by heart failure. To help you remember that the hepatojugular reflux maneuver involves checking JVP, we've drawn in this liver-spotted manatee jostling those big blue JVP jugs. Manatees. Nature's troublemakers. Or so I hear. I don't know. The history and physical exam are by far the most important aspects of a heart failure evaluation, which is why we've spent the majority of this sketch focusing on them. Let's now take some time to talk about the commonly ordered tests used to help aid in the diagnosis of heart failure. One of the most commonly ordered labs is the brain natriuretic peptide, aka BNP. Plasma concentrations of BNP and its sidekick NT-proBNP are elevated in patients with left ventricular dysfunction, especially from heart failure. At Sketchy, BNP is represented by a recurring symbol, the BNP blimpfish. Notice how their fins kind of look like the number 400? That's because most patients with heart failure have BNP levels greater than 400 picograms per milliliter. However, it's important to remember that an elevated BNP is only suggestive of heart failure. It can't make the diagnosis by itself. BNP is by no means the only lab you'll see ordered for a patient with suspected heart failure. It's simply the most powerful lab to help you make the diagnosis. We'll talk about a few other labs that are commonly ordered to rule out other diseases on the differential in a moment. Every patient with suspected heart failure should get an ECG, represented by that grid like fishing net, to help determine the underlying cause. Whether it's an old MI or existing arrhythmia, ECGs will pick up lots of potential cardiac causes of heart failure. Some types of cardiac ischemia won't be readily apparent, however, which is why every patient with suspected heart failure should undergo stress testing, represented by this old school treadmill, to evaluate for underlying coronary artery disease. Wow, that thing's still working under the sea? Man, they just made stuff better back in the day. Since heart failure most commonly presents with dyspnea, virtually every patient with heart failure will get a chest x ray as part of their initial evaluation. Typically, the first things that'll pop out to you are the fluffy bilateral opacities of pulmonary edema. At Sketchy, pulmonary edema is represented by the fluffy white lung shaped sail on this sunken ship. It's important to note that pulmonary edema is a nonspecific finding that can also be seen in many primary pulmonary diseases as well. Other findings suggestive of heart failure on chest x ray include cardiomegaly, represented by this large white whale swimming down the center of those lung sails. Wait, white whale? Are we getting our stories mixed up here? Officially, cardiomegaly is defined as a cardiac silhouette width greater than 50% of the total thoracic width on a postero-anterior chest x ray. See those curly folded lines on the edges of the sails? No, it's not seaweed. Those short horizontal lines near the periphery of the lung are known as curly B lines. Curly B lines are classically associated with heart failure and represent pulmonary lymphatic vessel congestion. Now take a look way up at the top of those sails. That upward branching seaweed represents cephalization of pulmonary vessels. Another chest x ray finding suggestive of heart failure caused by increased pressure within the pulmonary venous circulation. Finally, all the way at the bottom of these sails, check out that gross white algae. Notice how it's covering both corners of the sails? That's a recurring sketchy symbol for pleural effusions. Bilateral pleural effusions, to be precise. Bilateral pleural effusions are typically associated with non pulmonary conditions, so if you see it on chest x ray, heart failure should at least be in the back of your mind. Last but not least, we arrive at the mighty echocardiogram. The most useful diagnostic test in the evaluation of patients with suspected heart failure is the transthoracic echocardiogram. TTE is performed as a part of the initial evaluation in every patient with suspected heart failure because it allows us to identify many important features, including systolic and diastolic dysfunction. First and foremost, TTE is a non invasive way to accurately estimate ejection fraction, which is required to classify patients as having heart failure with reduced EF, defined as an ejection fraction less than 40%. TTE can also identify diastolic dysfunction, which can help diagnose the 50% of heart failure patients with preserved EF. Finally, TTE can also reveal other structural abnormalities that can contribute to heart failure, such as left ventricular hypertrophy or valvular disease, and clue you into the underlying etiology. Echocardiography is a powerful tool that should be used to confirm your clinical suspicion of heart failure. Now, when you're dealing with a disease as comprehensive and common as heart failure, it's almost understood that there are a ton of competing conditions on the differential. After all, heart failure is definitely not the only condition that can present with chronic dyspnea. Let's go through a few of the biggest diseases on the differential and the tests you would order to rule them out. One classic condition that also presents with chronic dyspnea is obstructive lung disease, specifically COPD, which, like heart failure, tends to affect older patients. If the clinical presentation of your patient isn't convincing, order spirometry testing. An FEV1 to FVC ratio less than 0.7 is indicative of obstructive lung disease. Keep in mind that, especially in older patients, COPD and heart failure can both present at the same time. So just because your patient has an obstructive spirometry pattern doesn't mean they can't also have heart failure. Indeed, the majority of your evaluation of a patient with suspected heart failure is done to distinguish it from a primary pulmonary disease process. Fortunately, the chest x ray is a great tool to separate most lung diseases from heart failure. Whether it's focal consolidation, reticulonodular interstitial markings, or mass lesions, the old school chest x ray can quickly point you towards the lungs or the heart in a patient with chronic dyspnea. Within the heart itself, one of the most important conditions to rule out is myocardial ischemia. Yes, I know that ischemic heart disease itself is a cause of heart failure, but active myocardial ischemia is treated in a much different way than heart failure. Therefore, order some cardiac enzymes, like troponins, and an ECG if myocardial ischemia is on the differential. Anemia is another sneaky cause of chronic dyspnea. Even if chronic anemia doesn't cause high output heart failure, which it totally can, It can definitely cause dyspnea on exertion. Order a hemoglobin and hematocrit to rule it out in a patient with suspected heart failure. All right, let's summarize our discussion of chronic heart failure with a sample assessment statement. Mr. Smith is a 64-year-old obese man with hypertension and diabetes presenting with 3 months of worsening dyspnea on exertion and progressive lower extremity edema. He now has shortness of breath walking around the house, but does not have symptoms at rest. Physical exam is notable for pitting edema of the lower extremities, elevated JVP, and an S3 gallop. Labs are significant for a BNP of 470. Chest x ray is significant for cardiomegaly and bilateral pulmonary edema. TTE reveals LV hypertrophy, severe LV diastolic dysfunction, and an EF of 55%. These findings are most consistent with NIHA Class 3 heart failure with preserved ejection fraction. That about does it for the clinical presentation of chronic heart failure. Let's wrap up this sketch with a quick run through of everything we've learned. Heart failure is a complex clinical syndrome resulting from any structural or functional impairment of ventricular filling or ejection. Heart failure can be classified into two different groups: heart failure with reduced ejection fraction, which is primarily caused by systolic or squeezing dysfunction, and heart failure with preserved ejection fraction, which is primarily caused by diastolic or filling dysfunction. Remember, heart failure is a clinical diagnosis based almost exclusively on the history and physical exam. Labs and imaging can help confirm the diagnosis once the H&P raise your suspicion for it. The classic presenting symptoms of heart failure include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, and abdominal distension from hepatomegaly and/or ascites. The most common causes of heart failure include ischemic heart disease, cardiomyopathies, valvular disease, and chronic uncontrolled hypertension, among others. One important way we classify the severity of heart failure is with the NIHA scale, which separates patients on the basis of activity limitation. NIHA Class 1 is defined as having no symptoms with ordinary activity. In Class 2, patients have symptoms with ordinary activity, which is in contrast to Class 3, in which patients have symptoms with less than ordinary activity. And finally, in Class 4, patients have symptoms even at rest. The most important findings to watch out for on physical exam include an S3 gallop, bibasilar inspiratory crackles, elevated JVP, pitting lower extremity edema, and a positive hepatojugular reflux. When your patient presents with some or all of these symptoms and signs, you'll likely want to confirm the diagnosis of heart failure with a BMP and, most importantly, a transthoracic echocardiogram. The echo not only helps you define which type of heart failure your patient has, it can also help you identify the underlying cause. Speaking of which, most patients with suspected heart failure will receive an ECG and a chest x ray in addition to the echo to evaluate for potential cardiac and pulmonary causes. That's it for now. Whew, I'm out of breath. Time to head to the surface. In part 2, we'll discuss all the things we can do for your patient once you've made the diagnosis of heart failure.